I am Michael Samarinas. I am a urologist. I am the head of the urology department of General Hospital in Larissa, in Greece. As you may have seen, we tried to correlate prostatic inflammation and detrusor overactivity. We understand during our clinical practice that there is a gap between detrusor overactivity and prostatic inflammation. Maybe these are the two edges of a line, in the center of which it could be bladder outlet obstruction due to benign prostate hyperplasia. So we tried to see if prostatic inflammation, the detrusor overactivity, the edges of this line, could correlate themselves in the era of BOO induced by BPH. This was our main thought before beginning this research. We know that prostatic inflammation could be a good cause a reasonable cause for BPH, and also that the detrusor overactivity could be a good result, maybe a bad result, after a prolonged BPH. So we tried to correlate these two phenomenically irrelevant parameters, but as you will see in the time of discussing, you will understand that maybe prostatic inflammation and the detrusor overactivity are not so irrelevant. Next step is to think about how can we correlate them. We need some data, some maybe objective parameters. So a good idea is to collect functional data, detrusor overactivity speaking, or histopathological data, prostatic inflammation speaking. So we recruited those patients who were eligible for transurethral prostatectomy. It's a special group of patients, but it's a everyday clinical practice group for most of the urologists. We performed urodynamic studies at the baseline. Then those patients who have validated bladder outlet obstructions were for a transurethral prostatectomy. And then we have another urodynamic study 3 months after the procedure, after the Tourpé. Actually, we found some disparities in prostatic inflammations according to the presence of the detrusor overactivity. So, in the beginning, we found that in those patients who have the detrusor overactivity, the rates of prostatic inflammation were higher. Or the opposite, the patients with prostatic inflammation was a risk factor for some patients to have the detrusor overactivity. This was a good disparity between the two groups. The group with the detrusor overactivity was the one, and the group without the detrusor overactivity was the other. So, in the group with the detrusor overactivity, prostatic inflammation seemed to be higher. After that, we had to evaluate prostatic inflammation histopathologically. How we could do that? It could be done with the help of a specific score of prostatic inflammation, and it was the Urani score, a specific prostatic inflammation evaluation score. So, prostatic inflammation was estimated in the Tourpé specimens, and then we performed the secondary urodynamic in the second at the 3 months later, 3 months after the procedure, as I said before. We showed that patients with prostatic inflammation had more possibilities to have a residual detrusor overactivity after the procedure. More interestingly, these patients with detrusor overactivity was those who have moderate to severe prostatic inflammation in the Tourpé specimens. So we concluded that apart from the higher rates of prostatic inflammation in those with detrusor overactivity, we concluded that patients with prostatic inflammation, especially the severe forms, had less possibilities to resolve the detrusor overactivity 3 months after the procedure. Actually, this is a type of research ongoing the last years by many urologists who are trying to, as urologists, we are trying to find those parameters so to have an indirect conclusion to prostatic inflammation, because, as we all know, prostatic inflammation can be diagnosed only by a biopsy of prostate. We cannot do biopsies to all patients. We do biopsies, we perform biopsies only in those who are susceptible for prostatic cancer. So we have to be guided by some parameters so as to make a good hypothesis that these patients with these parameters have many possibilities to have also prostatic inflammations. Prostatic size is one of them. But if you see the literature, you'll see that metabolic syndrome, PSA value, age, and other parameters could make us suspicious for the development of prostatic inflammations in a prostate gland. So the major need of this period, I think, is to be held as clinicians and researchers as well, is to validate a nomogram with all these parameters who could make a very good pathway from the suspicion to the absolutely conclusion that the prostate gland has also inflammations. We need more parameters than prostate size. A nomogram could make our job. All of this project has been performed because the resolution of male LUTs is usually very complicated. And it is usually very complicated because we do not know accurately the pathophysiological way from benign prostatic hyperplasia, bladder outlet obstruction, and severe LUTs or moderate to severe LUTs. All this work has to do with that. How can we find the pathway? How can we understand pathophysiology in order to have more effective treatment methods and, of course, happier patients and more satisfied doctors? This is the main aspect, the main way of thinking when we started this job. It was this research. It was how this complicated pathophysiology can be explained in that way that will be more effective to our patients. Last notice is that we are still waiting bladder specimen histology in order to have a holistic approach of the lower urinary tract in our research. We have bladder function, we have prostatic specimen, and we are waiting the results of the bladder specimens so as to see inside the detrusor.